Jaundice in early infancy. Key points. If significant jaundice is clinically suspected, a serum bilirubin level should be performed, as visual estimation of jaundice is unreliable. The majority of jaundice in well infants is physiological, and does not require investigation and management. Features suggestive of pathological jaundice include, onset and LT 24 hours old, unwell baby, elevated conjugated bilirubin component, prolonged jaundice, pale stool. Require prompt investigation and management. Background. Jaundice, or hyperbilirubinemia, occurs in approximately 60% of full-term and 80% of preterm babies within the first week of life. Hyperbilirubinemia occurs when there is an imbalance between bilirubin production, conjugation, and elimination. Kernicterus is a rare complication of neonatal unconjugated hyperbilirubinemia that can lead to major long-term neurological sequelae. Assessment. Jaundice within the first 24 hours. Unwell/febrile child. Dark urine and pale stools, biliary obstruction. Significant weight loss and GT 10% within the first week of life. Cephalohematoma or significant bruising. History. Feature. Further information. Age of onset, and LT 24 hours is pathological, and GT 2 weeks is prolonged. Antenatal course. Maternal blood group and antibodies. Maternal infectious serology. Birth. Birth trauma. Instrumental delivery. Feeding. Breast vs formula feeds. Poor weight gain. Output, hydration status. Dark urine and pale stools, biliary obstruction. Family history. ABO/rhesus. Spherocytosis/G6PD deficiency. Prolonged jaundice. Thyroid dysfunction. Examination. General tone. Neurological exam. Hydration status, capillary refill time, heart rate, mucous membranes. Plethora. Bruising/cephalohematoma. Hepatosplenomegaly. Pattern and degree of jaundice. Management. Investigations. Total serum bilirubin, SBR unconjugated, indirect, and conjugated, direct, then FBE and Coombs depending on clinical presentation. Transcutaneous bilirubinometers, TCB, can be used as a screening tool to assess bilirubin levels from 24 hours to weeks of age in near-term infants. Needs confirmation with serum bilirubin if within 50 micromole of treatment threshold. Reliability of TCB decreases after phototherapy commenced. SBR should always be used to check rebound levels. TCB/SBR should be plotted on an appropriate gestation-based chart/nomogram in order to determine need for treatment. Refer to local state guideline, see additional notes section below. Type. Causes. Investigations. Early onset, and LT 24 hours. Pathological. All should have. FBE, SBR, Coombs. Sepsis. Blank. Hemolysis, isoimmunization, ABO or rhesus D, alloantibodies, RBC enzyme, defects, G6PD, hereditary, spherocytosis, alpha, thalassemia, hemorrhage, cerebral, intra, abdominal, blood, extravasation, bruising/birth, trauma, FBE, film and reticulocytes, neonatal blood group. Direct antiglobulin test, Coombs. G6PD screen. Peak onset, 24 hours 14 days. No further investigations needed. Unless red flags. Physiological jaundice. No further investigations required unless red flags. Dehydration/insufficient. Feeding. Serum sodium, BGL. No further investigations required. Sepsis, blank, blank. Hemolysis, FBE, film and reticulocytes. Neonatal blood group. Direct antiglobulin test, Coombs. G6PD screen. Breast milk jaundice. Diagnosis of exclusion after considering above causes. Bruising, birth trauma. No further investigations required. And G. Prolonged/conjugated. and GT 2 weeks. All should have SBR, unconjugated / conjugated, FBE, film and reticulocytes, TFTs, group and DAT, LFTs if conjugated, bilirubin and GT 10%, sepsis, blank, hemolysis, FBE, film and reticulocytes, neonatal blood group, direct antiglobulin test, Coombs, G6PD screen, dehydration, insufficient feeding, serum sodium, BGL. No further investigations required. Breast milk jaundice. Diagnosis of exclusion after considering above causes. Hypothyroidism. TFTs, to exclude central hypothyroidism. Neonatal hepatitis. LFTs, maternal infectious serology, metabolic screening. Extrahepatic. Biliary obstruction. Biliary atresia. Choletical cyst, bile. Plug. LFTs, coags, abdominal US. Note, a normal ultrasound does not exclude biliary atresia. Metabolic. Alpha-1 antitrypsin levels, urinary reducing substances. Drugs/parenteral. Nutrition. Investigations as appropriate after history and exam. Treatment. 1. Assessment and treatment of jaundice. Severity of jaundice is judged based on a newborn's age and gestation, as well as clinical presentation, hydration status, and other risk factors. Please refer to local charts, see additional notes section below. Phototherapy. Refer to local protocol regarding intensity of lights required, including bili blanket use, and monitoring. Ongoing close monitoring of weight, hydration, and bilirubin levels should be performed during treatment as per local protocol, with serial checks of SBR to ensure resolution of hyperbilirubinemia. Exchange transfusion should only be performed in, or in conjunction with, a neonatal intensive care unit. Contact local pediatric retrieval service for support. 2. Treatment of the cause. Cause. Management. Sepsis. Blank. With 4 antibiotics. Hemolysis. Discuss with local pediatric services. Dehydration/feeding concerns. Hydration, feeding plan, and support. Consider maternal and child health nurse and lactation consultant involvement. Physiological jaundice. Exaggerated physiological response. Should resolve by 2-3 weeks. Breast milk jaundice. Diagnosis of exclusion. Do not stop breastfeeding. May last up to 6 weeks, no further bilirubin levels necessary, unless jaundice is deemed to be worsening. Hypothyroidism. Discuss with local pediatric services. Extrahepatic obstruction. Uncommon but early diagnosis improves outcome. May present with dark urine, pale stools and conjugated hyperbilirubinemia. Not excluded by negative abdominal US. If suspected, discuss with tertiary pediatric services within 24 hours. Consider consultation with local pediatric team when child is unwell. Cause of jaundice is unclear. Conjugated bilirubin is and GT 10% of total level. Consider transfer when jaundice level rising despite adequate treatment offered at your local center. Patient needs exchange transfusion. For emergency advice and consider discharge when causes requiring further treatment or investigation have been baby is clinically well and feeding well. Discharge advice. Sunlight exposure is not recommended as a treatment for jaundice. Arrange early follow-up with maternal and child health nurse and/or GP to ensure adequate oral intake, especially if and LT 7 days old. Exclusively breastfeeding or still establishing adequate oral feeds. Bilirubin level is borderline for requiring treatment. Recheck bilirubin in 24-48 hours if borderline level or still rising. Parents should be advised to seek medical review if jaundice is present for 2-3 weeks and cause has not previously been established. Parents believe jaundice is worsening or there is any other cause for clinical concern.